Hey there. So if you're a nursing student, especially in peds, you know the heart can feel super complicated, right? Like this intricate puzzle. But what if we just thought of it as a plumbing system? Today, that's exactly what we're going to do. We're going to dive into 3 really common leaks that cause a huge overflow problem for our little patients. Ready to jump in?
All right, here's our game plan. We're going to start with the big problem, too much pulmonary blood flow. Then we'll look at the 3 culprits, the PDA, the ASD, and the VSD. And we'll wrap it all up with a little nursing know-how, a comparison chart to really lock it all in.
Okay, first up, let's get our heads around the core problem here. We're talking about too much blood flow going to the lungs. Now, all 3 of the heart defects we're covering today have this one thing in common. It's the central issue we need to understand. So, what does this actually mean? Well, it all comes down to pressure. Think about it. The left side of the heart is the powerhouse, right? It's got to pump blood to your entire body. The right side, its job is way easier. It just has to pump blood right next door to the lungs. So the left side is high pressure and the right side is low pressure. Now, if you have a hole or an abnormal connection between these 2 sides, where do you think the blood's going to go? It's going to take the path of least resistance, flowing from that high pressure left side back over to the low pressure right side. We call this a left to right shunt. And all that extra blood that's shunted over, it gets sent right back to the lungs, creating this massive overflow. So, what's actually causing this overflow? Well, that leads us right to our 3 main culprits. These are the leaks in our plumbing system that create those abnormal connections we were just talking about.
All right, let's talk about our first leak, the patent ductus arteriosus, or PDA. You're going to see this one a lot, especially with preemies. It's basically a little passageway that's supposed to be there before a baby is born, but it becomes a real problem when it just refuses to close up shop after birth.
Okay, so let's look at the plumbing here. The aorta is like the main interstate highway, carrying all that oxygen-rich blood from the left side of the heart out to the body. The pulmonary artery, that's more like a local road, taking blood from the right side just to the lungs. A PDA is a little connecting vessel between this highway and the local road that just stays open. That's what patent means. So what happens? That high-pressure blood from the aorta takes a wrong turn, an illegal U-turn if you will, right back into the pulmonary artery, and boom, the lungs get totally flooded with extra blood they weren't expecting.
So, what are you, the nurse, going to see and hear at the bedside? Well, you'll put your stethoscope on their chest and you're going to hear a classic systolic murmur, often described as machine-like. You'll hear crackles in the lungs from all that extra fluid, and you'll see the result of that, fast breathing or tachypnea, and just increased work of breathing. These babies are working hard. When you check their pulses, they'll feel super strong, what we call bounding pulses, and you'll notice a wide pulse pressure. Of course, all this extra work is exhausting, so you'll see poor feeding, fatigue. These little ones might even break a sweat just trying to take a bottle. It's a huge clue. On an x-ray, you'd see what you'd expect, an enlarged heart from all that overwork.
So how do we fix this? Good news is, a lot of the time, we can use medication to convince that little vessel to close. Indomethacin and ibuprofen are your go-tos. They're both NSAIDs, and they work by blocking something called prostaglandins. Think of prostaglandins as the chemical signal that was telling the ductus, hey, stay open, before birth. By blocking that signal, we're basically telling it, okay, party's over, time to close down. Acetaminophen can also be used, and it works in a pretty similar way. This is super important pharmacology to know for peds.
Okay, on to our next plumbing problem. This time, we're not talking about a leftover vessel. We're talking about an actual hole in the wall of the heart. This is the atrial septal defect, or ASD.
So with an ASD, the hole is in the septum. That's the wall between the 2 top chambers of the heart, the atria. Now, the location's different, but the physics, it's exactly the same. Pressure is higher in the left atrium, so that fresh oxygen-rich blood that just came back from the lungs takes a detour. It leaks through the hole over to the right atrium, mixes with the deoxygenated blood, and gets sent right back for another trip to the lungs. Again, we've got that pulmonary overflow.
When you're assessing a kid with an ASD, pretty much everything you find points back to the strain on the right side of the heart. You'll hear a murmur for sure. You'll see shortness of breath. And just like with the PDA, these kids get tired out really easily, especially when they're eating, which can mess with their growth. Over time, all that extra blood volume makes the right atrium and the right ventricle get bigger and stretched out.
And this is a big one to remember. If it's not fixed, there's a higher risk of developing emboli, little blood clots, down the road.
So how do we manage an ASD? Well, sometimes we start with meds. Things like digoxin or diuretics can help ease the workload on that struggling right side of the heart, so you'll be monitoring for signs of congestive heart failure. But really, the ultimate fix is to plug the hole. And a lot of times, this can be done pretty non-invasively through a cardiac cath procedure where they can deploy a little closure device. Another key nursing point is prevention. Before certain procedures, like even getting their teeth cleaned, they might need antibiotics. Why? To prevent something called endocarditis. That turbulent blood flow can rough up the heart lining, making it a perfect spot for bacteria to stick and cause a nasty infection.
Okay, last but not least, our third plumbing problem. And this one is the most common congenital heart defect of them all. We're talking about the ventricular septal defect, or VSD.
So, a VSD is just like an ASD, a hole in the septum, but it's lower down, between the two main pumping chambers, the ventricles. And this is a big deal because the pressure difference here is massive. Remember, the left ventricle is the strongest chamber in the whole heart. So when there's a hole, blood doesn't just leak, it shoots across from the left ventricle to the right. And where does it go from there? You know it, straight back to the lungs for another round. Now with VSDs, size is everything. A tiny little pinhole might not cause any problems at all, but a large one can cause very serious symptoms.
Okay, for your nursing assessment, a VSD has a really unique sign you need to know about. Of course, you'll hear a murmur, but with larger defects, you can actually feel it. It's called a systolic thrill. When you put your hand on the child's chest, you'll feel this buzzing or vibration. That's the feeling of that powerful jet of blood rushing through the hole. It's a pretty wild thing to feel. Besides that, you're looking for the usual suspects: shortness of breath, trouble eating, what we call failure to thrive, and because their lungs are always extra wet, they tend to get a lot of respiratory infections.
So what do we do about VSDs? Well, remember how I said size is everything? That dictates the treatment. For a lot of the small ones, we actually do nothing. We just watch and wait, because many of them will close up all by themselves as the child grows. But for the larger ones that are causing problems, surgery is usually needed. This is a bigger deal. It often involves a sternotomy or opening the chest to go in and place a patch over the hole.
All right, you've made it through our 3 big leaks. We've talked about PDA, ASD, and VSD. Now, let's put it all together. Think of this next part as your ultimate nursing cheat sheet to help you tell them apart when it really counts.
So let's break this down. For PDA, remember the location is that vessel between the big arteries, the aorta and pulmonary artery. Your key sign, those bounding pulses and that classic machine-like murmur. And we often fix it with meds like indomethacin. For an ASD, the hole is higher up, between the atria. Your clue is a murmur and signs of that right side of the heart getting bigger. Intervention often involves diuretics and then a less invasive cath lab closure. Finally, the VSD. The hole is down low, between the ventricles. The hallmark sign you can feel is that systolic thrill, and these kids get a lot of respiratory infections. And for the big ones, the fix is a surgical patch. See how the location, signs, and treatment all connect?
So there you have it. We've gone through the plumbing, the symptoms, and the fixes. But now the real question is for you. The next time you're at the bedside and you hear a new murmur, or you see that tiny baby sweating just to finish a bottle, how is this going to sharpen your assessment? How will you start connecting those dots to what might be happening with the plumbing inside that little chest? Because that right there, that's the critical thinking that truly makes a great nurse. Thanks for joining me.